Hello class, hope everything is going great. We are in chapter 7 of your textbook, so if you would like to have your textbook out, you can turn it to page 113 and sort of follow along too, along with the PowerPoint that I know you have printed out or looking at on another screen. So we're in the immune system, or just talking about in general, immunity. The immune system is responsible for our body's defenses, and it's going to protect us both from cells that are worn out and could cause damage, and from foreign invaders that we kind of saw in the infection chapter. So we have two different kinds of response. We have a non-specific response, and then we have a very specific response. And so there's two responses, and you hear them called different, called different things. But the non-specific response is primarily going to do phagocytosis of the invader or inflammation. So it's very non-specific, and it's really our first line of defense. The specific response or specific defense is actually going to be where we produce specific antibodies that are going to attack specific substances, and that takes a little bit of time for us to develop these antibodies. The components of the immune system, we have three parts. We have the lymphoid structures, immune cells, and then we also have the chemical mediators. So the lymphoid structures are our lymph nodes that we're all familiar with, the spleen, the tonsils, the intestinal lymphoid tissue, and lymphatic circulation. So we're sort of kind of talking about the lymphatic system. And as you know, that's a one-way system that is connected by vessels in between, and it all goes one direction towards the heart. These are going to house lots of white blood cells, and there are also going to be places where we see specific cells that are going to be able to attack any foreign bodies. And a lot of times these are some of the first places that sort of kind of accumulate, white blood cells and swell and have inflammation. Also, we have to talk about the specific immune cells, which are going to be primarily our white blood cells. We have the lymphocytes, which produce these specific immune responses, and then we have macrophages, which develop from monocytes. If you remember the different white blood cell types, macrophages were developed from monocytes. Then we have our tissues, and they allow our immune cells to develop and grow. All immune cells, or we say white blood cells, start in the bone marrow, and they develop in the red bone marrow. In adults, it's typically the femur and some flat bones. In infants and the fetal, it's in fetuses. They are all bones that have these that produce the blood cells, and they typically go to secondary sites where they can develop, and this is where we see T cells develop. They actually develop in the thymus, and that's where they get their name T cell from, or T lymphocytes. They actually are developing. They grow in the bone marrow, and then they move to the thymus, where they continue to mature. And here you can see just some of the different parts of the immune system. You can see the pharyngeal tonsil, which is up in the pharynx. The palatine tonsil, or the ones we typically talk about that we say are tonsils. We have lymph nodes in our neck and throughout our whole body, and that run through. We see lots under our armpits and in our groin area, and they're going to be all throughout the whole entire body. And then we have some other organs such as the thymus and the spleen, which house a lot of white blood cells, and a lot of blood flow circulates through these organs. Then we also see the bone marrow, which is where our white blood cells are developing. elements of the immune system. We need to first establish is our immune system going to protect us against, and pretty much what we call anything that our immune system will attack is going to be some type of antigen. And we can break antigens into two different categories: self versus non-self. Self antigens are ones that we produce, and we find them on our cells and throughout our body. Okay, it allows us to know the other cells to know that it's our cell. Okay, and then we have antigens that are non-self, which are foreign antigens that came into our body, and we need to be able to recognize that is not ourself. So we always have to, our white blood cells always have to be able to distinguish between self and non-self. One of the ways that we know that our cell is us, is our cell, is through the human leukocyte antigen proteins. These are proteins that are coded for by the major histocompatibility complex, DNA. And this complex is unique to each and every one of us. And it's a basically a glycoprotein that we produce, and each person has a different one. And our immune cells are basically, as they develop, they're trained not to attack any cell that has our human leukocyte antigen. Okay, this goes against cells, and they go against the cells that are non-self, so they're foreign. And so as our cells that do that specific immune response develop, they are going to kind of be weaned. So if it attacks us, it will be destroyed. And if it attacks the non-self, it will live. And if it really goes all the way over to the other side of the room and attacks something that's totally bizarre, it usually gets destroyed also. So it sort of kind of keeps them in a range where the antibodies or whatever's going to attack the antigens should be somewhere in between self and like really far out there non-self. It should be, so we're only going to attack things that are sort of kind of like us, but not quite. Okay, so that's where we want to be at. The development of the specific response to a particular antigen, and then later on, if we encounter that antigen again, that non-self antigen again, we will quickly produce more antibodies to attack that antigen. So what are the antigens we usually talk about? When we say antigen, we're typically not talking about our self antigens, we're talking about our non-self antigens. And they're usually exogenous substances, which means they are they're foreign substances that are found externally. And they're often cell surface proteins, or antigens, we should say. And these antigens could be a protein that has a very specific amino acid sequence, a polysaccharide that is unique to that foreign invader, or a glycoprotein, which is a carbohydrate and a protein. And basically what we're looking for is something that is not ourselves, that is easily identified by the antibodies. Some of the cells of our immune system. One of the big ones are macrophages. And macrophages do phagocytosis. And macrophages are a very innate very non-specific immune responder, and they initiate the immune response. They develop from monocytes, which are a type of white blood cells, and they're part of the mononuclear phagocytic system, cytotic system. So that just means monocytes, they have one large nucleus and they go around phagocytosing worn out parts or even foreign material. They typically engulf the foreign material, whether it be a virus or bacteria, and after it engulfs it, all the little parts that kind of are antigenic will be pushed to the surface of the macrophage, and the macrophage will present the antigen that it ingested to a T cell or a B cell, and it's going to attract those T cells and B cells, and they're going to bind to the antigen, and then they can go on from there by either, if they're B cells, producing antibodies, or T cells go attack that foreign material if they see it again. And macrophages are throughout the whole body, and they secrete, like I said, those chemicals like monokines and interleukins to introduce inflammation to the area and also attract those other cells. The next type of cells are the lymphocytes, which are the T cells and the B cells. So T lymphocytes are called T lymphocytes because they mature and differentiate in the thymus. So they're produced from the red bone marrow stem cells, the same stem cells that produce the red blood cells and the white blood cells and the platelets. But they differentiate into T cells. They go onto the thymus to differentiate. T cells primarily do what's called cell-mediated immunity. Okay, why we call it cell-mediated immunity? Because the T cells are going to mediate that immune response. So the T cells are going to be directly involved in going out and phagocytosing and destroying, well, not necessarily phagocytosing, destroying the antigens. Okay, and so it's mediated by the actual cell, which contrasts with humoral immunity, which deals with the antibodies. So the T cells is cell-mediated immunity. Primarily by T cells, we have the cytotoxic T killer cells. So they actually will destroy specific antigens, cancerous cells, and virus-infected cells. So if you look at these last two parts, it's really really kind of specific to cytotoxic T killer cells, because they will kill cells that look very similar to our cell. However, there are going to be slight differences in the way the cell membrane looks due to the presence of some antigens. And those cytotoxic T killer cells are going to be able to identify this cell as a cancerous cell, or this cell has been infected by a virus. So it can go out and destroy that cancer cell or virus infected cell. Then we have other T cells that are helper T cells, and those are going to help activate both B cells and T cells. So they go on to activate other cells. Then we have memory T cells, which will help us if we get exposed with the antigen a second time. And it's going to increase the response time because those memory T cells are going to be circulating, ready to kill that antigen the next time it comes into the body. And then the other type of lymphocyte we have is the B lymphocyte. It is responsible for the production of antibodies. And we've all heard of antibodies before. They're little, basically Y-shaped proteins. They're made of, have a few different chains, but they make a little Y shape. So if you like put your hands up in the air and like doing the YMCA, you see the Y, it would be the part where your arms are up. That would be the part that will actually attach to the antigen. And so by varying the region of the antibody in the Y in the arms, we can attack different antigens. And this is called, and these B lymphocytes produce these antibodies. Okay, and the lymphocytes, the B lymphocytes are going to be involved in that humoral immunity because they're dealing with the dissolved antibodies in our blood. So they're in our blood, and that's why it's called a humoral immunity. B lymphocytes mature in the bone marrow. That's why they're called B. And then they proceed to the spleen and lymphoid tissue, where they remain until they come across a antigen. And once they are presented with the antigen, then they begin producing those antibodies. Okay, and once they produce those antibodies, they are called plasma cells. Okay, so the B lymphocytes go out and live in the spleen and lymphoid tissue, and they produce a small amount of antibodies. And if their antibody actually interacts with the antigen, then that cell will mature even further into a plasma cell where it really cranks out those antibodies. And afterwards, some of them may become B memory cells, which can actually clone, and they clone each other if they're exposed with the antigen again. So if it gets exposed by a second antigen later, the B memory cells can rapidly divide and produce a slew of antibodies to go ahead and knock it out and prevent a severe infection. So there are two types of immunity we've already kind of talked about. Is the humoral immunity, which deals with the antibodies that are produced to protect the body. And then we also have the cell-mediated immunity, which is the T cells that are programmed to attack non-self cells. Okay, so there are T cells that are programmed to attack non-self cells, or cells that are kind of went out of whack, like those cancer cells or virus infected cells. So we can see here on our screen, we can see that all the cells of the immune system are produced by the bone marrow. Typically, like I said, the head of the femur and some flat bones. And they come from lymphoblasts. And those lymphoblasts differentiate into the ones that remain in the bone marrow, differentiated into the B cells, and then the ones that go on to mature in the thymus become the T cells. Okay, they both migrate to the lymph nodes in the lymphatic system, and if they encounter a antigen, they will become one of the four types of T cells. So they are sensitized when they come in contact with that antigen, and they will present it to the B cells, and they will either destroy or present it and help the B cells, I should say. And that's going to cause the cytotoxic T cells to actually kill the antigen, or it could also cause the helper T cells to stimulate the plasma cells to produce the antibody. Okay, and that antibody, due to the presence of the antigen, will go out and bind the antigen, and it's going to attract cytotoxic T cells. It's going to attract those macrophages. Once those antibodies are bound, it can also attract the complement sequence, which we'll talk about in a second, which basically bores a hole into the cell wall of the cell that has the antigen and allows for it to be lysed. So we can see all kinds of things happen due to the antibodies bound to the antigen. So what are the names of the antibodies? You do need to know these and know a little bit about each one. So another name for antibodies is immunoglobulin. Okay, or antibodies, or immunoglobulins. So we can call them immunoglobulin G. Okay, that's the G. It's the most common in the blood. Okay, then we have IgM, which is the first one to increase during immune response. Then we have IgA, which we find in the tears, the saliva, mucous membranes, and the colostrum. Okay, so we see in a lot of secretions, small amounts of IgA. Then we have IgE, which is going to stimulate histamine and other chemicals, and we also see it in lots of allergic responses, and it's going to have the ultimate result of inflammation. So that's IgE. And then we have IgD, which is attached to B cells. So the antigen IgD is on the B cell so that it can activate B cells to produce even more antigens and become those plasma cells. The complement system is activated, I talked about this a while ago, by either the IgG or the IgM antibodies or immunoglobulins. This complement system consists of several different proteins that are all circulating separately in the blood. There's 9 of them. C1, 2, 3, 4, 5, 6, 7, 8, 9. And when there is cell damage, when they get activated, these complements kind of bind together and they will either cause the antigen to lyse and cause cell damage, or they will cause even further inflammation at that site. And inflammation is what? Heat, redness, swelling, increased permeability. And so the complement system basically helps to destroy the antigen if some kind of microorganism is inside of our body. So that's the complement system, and it uses both IgG and IgM antibodies. We also have a lot of chemical mediators that these cells will produce, and not only these immune cells, but other cells in the body that will also produce these chemical mediators to do various things such as signaling or causing inflammation or cell damage. Some common ones are histamine and interleukins. Okay, so it's going to be signaling and causes cell damage. The immune system, we can actually test for certain diseases by looking for the antibodies that are produced and what antibodies are in the blood. So by doing a titer, we measure serum immunoglobulins, the antibodies. So we can do a titer to see if the Zoroaster virus is ever been affected by chickenpox. We can see if there's any level of antibodies circulating in our blood. Okay, and they do make people do these before getting certain jobs in the medical field. We can do an indirect Combs test, which detects the Rh factor, which is one of the the blood types, whether you're positive or negative. So we can detect that. We can use a ELISA, which is basically an enzyme-based absorbent, where we phosphorescent the different antibodies, and we can see if they're there. Okay? So it detects the HIV antibodies. Then we can also do typing of the major histocompatibility complex, which is remember what I told you is self versus non-self. Okay, and we do this before before a transplant to make sure that the major histocompatibility complex matches up as best as possible. We're also going to try to test blood types and things like those natures. So basically, if you really want to think about it, you're probably familiar with like blood types A, B, and O. We probably talked about that in any other anatomy classes. But the major histocompatibility complex is a step deeper than just the simple A, B, and O. Okay, if you really want to think about it, you think about it's very, very specific. It's more towards a fingerprint of each cell that you made in your body. Okay, so it's really important to match that up. Okay, and we can talk about immunity a few different ways. One way of talking about immunity is natural immunity, which is just our natural predisposition as the human species not to get a virus that affects cats, for example. So it's a species specific that prevents some type of microorganism from attacking our species in particular. So we don't get the same diseases cats get, or we don't get the same diseases as dogs gets. So it's called a natural immunity. Okay, so we just have a natural immunity to that. Then we also have an innate immunity, which deals with the specific genes each one of us have, and typically we see this gene specific, and a lot of it has, as far as gene specific, has to do with our lineage, our heritage of our that has been passed down. So it's related to ethnicity. So, for example, the Native American tribes before colonization, they were not really exposed to tuberculosis very much. So when they were they had no innate immunity to tuberculosis. So that population after colonization experienced very high rates of tuberculosis. They had no innate immunity. So then we have just dealing with immunity. We always have a primary response to an antigen, and then we have a secondary response to the antigen. The primary response is the first time we're exposed, and actually takes a couple weeks before our antibodies are in sufficient number to actually eradicate and get rid of that antigen. Okay, so this takes a couple weeks for efficacy. Okay, so it takes a couple weeks. That's the first response. The second response, due to our memory B cells or memory T cells, is more rapid, and we typically can have efficacy in 1 to 3 days. And we might not even know that we were reinfected with that same antigen. Okay, this is one of the things we try to get as that primary response when we do vaccinations. Okay, so we can see here, here's our serum antibody level. It shows you how many antibodies we have in our serum. It's a titer. And we can see the first response, we produce just a few antibodies. Very small amount, takes a couple weeks. Then the second time around, the same antigen exposed, the same microorganism, however you want to think about it, you see that it's very rapid. There's no delay between the time of exposure and the increase in antibodies, because we have those memory cells. And so it shoots up and it pretty much eradicates it very quickly. Okay. Also, when we're talking about immunity, we can talk about active and passive immunity. Active immunity is where we're actually developing that resistance ourselves. And active natural immunity is just a natural exposure to that antigen, and it produces an immune response. So you're exposed to chickenpox, the virus chickenpox. Your body goes, you get sick, you produce the antigens, blah, blah, blah. Some of those cells go on to become those memory cells. So now you have an active natural immunity to chickenpox. You're only going to get it one time. That's natural and it's active. So you actually go through the process of getting the disease and you develop that immunity. We can stimulate that artificially with vaccinations and immunizations. So the antigen is purposely introduced in the body. Hopefully, usually, it's a harmless version of that antigen. So maybe just the proteins that were found on top of that bacteria, or the proteins produced by that virus. And so when our body sees it, that antigen, it will attack it readily as a secondary response. So we're not going to get that sickness. Now those two both involve going through the process of exposing the antigen, producing the antibodies, forming the memory cells. Okay, that contrasts with passive immunity, where we're actually just transferring antibodies. So passive natural immunity is where the antibody G, immunoglobulin G, is transferred from the mother to fetus. So this is the natural process, and it can be transferred two ways: across the placenta. Okay, the placenta is what connects, the fetus with the mother, and believe it or not, the blood doesn't mix, right? It doesn't mix. Okay, they just go up to each other in the placenta, the blood vessels, and it transfers across. Okay, and then it can also transfer some through the breast milk. That's one of the reasons why they say breast milk is so good for infants, is because it produces some IgG. Okay, and this will protect the infant for the first few months of their life, or until weaned. Then we have artificial passive immunity. So passive artificial immunity. This is where we actually taking the serum from one person, taking those antibodies, and injecting them into another person. And we did see this happen with the Ebola virus. One of the doctors that had the Ebola and they survived, they gave some of their serum with the antibodies to another person. I think it did work. It did work. They did some type of blood transfusion. So that'd be passive artificial immunity. Immunosuppression is the depression of the immune system, usually purposefully. And the main reason why immunosuppression is done is so that the organ that is transplanted to the host will not be rejected. And some common drugs are cyclosporin, prednisone, azathioprine. These drugs suppress the immune system. Prednisone is a glucocorticosteroid, and the steroids typically depress the immune system. And this is fine. Purposely suppressing the immune system allows for that organ not to be rejected, but at the same time, it greatly increases the risk of infection. You can sometimes see very opportunistic organisms that normally don't cause an infection will become infectious. So you might see someone growing yeast in their stomach or growing yeast into their small intestine. Normally the immune system will knock that out, will never happen. But due to being immunosuppressed, it could those types of things could happen. Next thing we're going to talk about are hypersensitivity reactions. There's 4 different types of hypersensitivity reactions. You need to know the cause and the basic cause and some of the complications. Maybe an example of 2 of each one. The first type is what are just called type 1 hypersensitivity, and it's what we typically think of as an allergic reaction. The cause is some kind of allergen. Okay, an allergen is an antigen that the body reacts to, but it's really not a microorganism. Okay, so it's not something that would cause an infection normally. So, for example, pollen. Pollen is not going to invade your system and spread and cause an infection. But your body kind of gets tricked to thinking pollen is bad. It's a microorganism. So that protein acts as an antigen and it will cause an allergen. So some common ones, like I said, is or skin rashes, hay fever, asthma. Okay, so you're exposed to the allergen, and what happens is you develop immunoglobulin E's, IgEs. So remember that, IgEs. They are specific to that allergen. Those antibodies form against something that is benign. Nothing that's really harmful. Those antibodies are formed to that allergen, commonly like pollen and those types of things. And so it is presented to the mast cells. So those IgEs develop and they present to the mast cells, and they get on top of the mast cells, and now those mast cells are stimulated. And when those mast cells stimulate, they get it stimulated, they produce massive amounts of histamine. And that histamine is going to cause anaphylaxis. Okay? So we'll just talk about a little bit more. So hay fever, his actual name is allergic rhinitis. Okay? And it's where the nasal mucosa is inflamed due to those mast cells producing that histamine, because we are attacking that pollen that we breathed in. We also see it with food allergies in the digestive tract mucosa, where those mast cells are producing that stuff and it's going irritable, inflamed. We see atopic dermatitis and eczema. Those are both allergic reactions that we see in our skin. And asthma is where it happens in our bronchial mucosa. So you see, one of the common things is these are all membranous surfaces that are exposed to the outside environment. Okay. And we do see that with hypersensitivity 1, it kind of does trend through families, and allergies kind of, so there is some kind of genetic component to predisposes people to allergies or type 1 hypersensitivity. So we see here's our allergen, we get exposed to it, it's okay. But guess what? It shouldn't really react with it, but IgE reacts with it. So we produce these IgEs, these antibodies that are going to attack this allergen, this benign foreign body. Okay? And now the antibodies form and they work with those mast cells and basophils. Okay? If you remember, basophils dealt with immune response also. And those mast cells, basophils, are sensitized now. They got those antibodies attached to them. So next time they get that allergen, they go crazy producing that histamine. And we're going to see some of the effects here of this histamine, but the primary one is inflammation and vasodilation. And that stuffiness, right? And swelling of that nasal mucosa. And so that's type 1. Type 1. So, and it could be any kind of allergy. Allergen could be cause type 1 hypersensitivity. So, and if the exposure is like super high, or you're super allergic, say super, we can end up having anaphylactic shock. Okay, this is a severe, life-threatening, acute illness. Okay, it needs to be taken care of rapidly, and it's where we have systemic hypersensitivity. So systemic meaning throughout the whole body. Okay, so we're being exposed, and the histamine and the chemicals are going throughout our whole body. So one of the first things that's going to happen is a decreased blood pressure due to the histamine. So it's going to cause vasodilation. So all our blood vessels are going to relax, and our blood pressure is going to drop. And this is going to go in with the opposite of airways, because histamine makes our airways contract. It makes the bronchioles contract and constrict, and that's going to cause us not to be able to breathe quite as well. will also can cause swelling of the larynx, of the trachea and the pharynx, okay, which can make breathing harder. Very common thing. Some common things that can do it is latex, insect stings, nuts, shellfish, and various drugs can all cause this. If you ever watched the movie Hitch, you know, he ate some bad shellfish. He saw his face swell up and he couldn't breathe. And he had to get some antihistamine, Benadryl. So it is kind of dangerous. Some signs and symptoms: itching all over, tingling, especially in the oral cavity if it was orally ingested. Coughing, difficulty breathing, feelings of weakness, dizziness, fainting, fear and panic, swelling, hives, collapse, and loss of consciousness. So it's very, like I said, life-threatening. And you can see it's just a storm of histamine. Okay, so we've released this histamine storm, and it's going to cause blood vessels to dilate and increase permeability. Okay, it's going to cause lots of inflammation, swelling, edema. Okay, it's going to cause nerve endings to be irritated and cause that itching. Okay, decreased blood pressure. It's going to cause the airways to constrict. Okay, it's going to cause edema to occur, mucus obstruction. So we're going to have severe oxygen deficiency due to the decreased blood pressure and the air obstruction. And that's just going to be that's the life-threatening part of it. Okay, treatment. First off, the best thing to do is to know if the person that you are with has any severe allergies, because the first thing you want to do is they have it is to administer EpiPen. And most people who carry EpiPen, is usually they're allergic to bees or things like that, but you should carry one even if you're allergic to shellfish and certain food allergies, because you never know what might have got mixed in at that restaurant. Call 911, and once they get you there, they usually treat with epinephrine, okay, glucocorticoids, which are going to do what? They are going to decrease the immune response. They're immunosuppressants. Antihistamines. If you give an antihistamine in time, it will block the receptors for the histamines, and that will help decrease the effect of that histamine. Oxygen, due to the obstructive airways and low blood pressure, it just increases the concentration. And then we want to stabilize the BP. So we're going to give some kind of meds for increase the BP. Okay. So that all went with type 1. It's that allergic reaction. Okay. Can be severe, can be slight. Okay. That's type 1. Type 2, cytotoxic hypersensitivity. Okay. Cytotoxic. Dealing with the cells and toxin, right? Cytotoxin. So this is where the antigen is present on the cell membrane. Okay, so it's on the cell membrane. Typically, it would be some kind of exogenous substance on some kind of microorganism, or it could be a normal body component, one or the other. Okay, but the antigen is on the cell membrane, and the circulating IgGs, that was one of the ones that were passed from the fetus to the mother, reacts with the antigen. So the circulating IgGs react with the antigen. This results in phagocytosis / cytolytic enzymes destroying that cell. Okay, so because it's on the cell membrane. Now, the best example of this is an incompatible blood transfusion. Okay, so the antigen was on the surface of the cell. So you gave type B blood to somebody had type A. So they formed antibody to it. IgG goes out there and it binds and kills the type B blood. Okay. So the antibodies and type B blood mix with the type A blood, and it goes and binds it. Okay, and all those antibodies will activate that complement system. You remember the complement system? I told you it will bind to cells and lyse them. And so you lyse them, and you lyse enough cells, you can have all kinds of problems. And then that lyse cell can undergo phagocytosis. And if it's massive enough, you can get really, really sick from blood transfusion from the wrong blood cell type. Okay. Type 3. Type 3 is immune complex hypersensitivity. So in type 3, it's type 1 cytotoxic. Type 2 cytotoxic. Type 1 was allergies. Type 2 cytotoxic. Type 3 is immune complex. So basically, the antigen and antibodies are going to form a complex. And that complex is going to deposit into tissue. Okay, and it's going to cause inflammation and tissue destruction by activating the complement system. So you just got basically this antibody bound to the antigen, and it's floating around and gets deposited in tissue. And once it gets deposited, it can cause that tissue it's depositing to be self-destructive. Okay, we're going to destroy that tissue. So glomerular nephritis, which is going to be when it's laid down in the nephron of the kidney and the glomerulus of the nephron. You can see that it could cause inflammation and kidney failure. And then also when it deposits in the synovial joints, we can end up getting rheumatoid arthritis and that inflammation and swelling of those synovial joints. Okay, and we can see here, so we have our antigen, it gets into the blood, and then our antibody. We form these little complexes where they bind together. Okay, we activate that complement, those little C1 through C9. Okay, the antibody gets deposited in. This looks like the glomerulus, somewhere like that. Okay, it deposits, and then what are we going to do? Destroy that tissue. So it deposits, gets destroyed. Not very good. Anyways. Then lastly, but not least, is cell-mediated or delayed hypersensitivity. This is type 4. Okay, so it's delayed. And this deals with, since it's cell-mediated, we know we're dealing with T cells. And it is delayed. It usually takes, it can take 24 to 48 hours for it to happen. It's a delayed response to the allergen. Basically, we'll say the allergen, allergic reaction. But it's due to sensitized T lymphocytes. Those T lymphocytes in our body, they're circulating. If they're sensitized to whatever that antigen is, when they come in contact with it, they release those lymphokines, which is a chemical mediator. And those lymphokines produce an inflammatory response. Okay, they're going to try to destroy that antigen. Okay, now in some circumstances that's good, right? Because we want to kill the antigen. But other circumstances, the antigen might not necessarily be, really this bad microorganism invading us. Okay. But it could be latex, and that latex could wear those we could wear those gloves and have that latex on her. And then about 2 days later, our hands are broke out everywhere because the T lymphocytes have released those lymphokines and tried to destroy that latex that's not even there anymore. So it is a hypersensitivity. This is how we conduct the tuberculin test, which is for tuberculosis, where you just get a little injection right under the skin. And if you've ever had tuberculosis, you have sensitized T lymphocytes that developed in your lungs, and then when you inject it on your skin, they go out there and they will attack that antigen in the shot. But it takes a couple of days, and that's why you have to go back and get it read, because it's the sensitized T lymphocytes. contact dermatitis from contact with like latex, and then allergic skin rashes. Okay. Also, we have the autoimmune disorders. Okay. Auto means what? Self, and then immune. So we're attacking ourselves with our immune system. This is where we develop antibodies against our own cells. It shouldn't happen. We should, when they're developing it, if it's really close to looking like ourselves, they should be destroyed. Those T lymphocytes and B lymphocytes should be destroyed. Sometimes they're not. And those cells will end up producing autoantibodies. Okay? And they form against self-antigens. So we're no longer tolerant of ourselves. And this really isn't any kind of joke, because it can have very bad results. And depending on where the antigen, the self-antigen is found throughout our body, it can either affect one organ or lots of tissues. It could be very localized or very generalized. Example of a localized one would be just Hashimoto's thyroiditis, where we're attacking the thyroid. Systemic lupus erythematosus is a more systemic one, a generalized, affecting the digestive system, the skin. Erythematosus is the red butterfly patches that you can actually see on people's faces, across their nose and across their cheeks. Rheumatoid fever, rheumatic fever, myasthenia gravis, which we'll talk about later a little bit, and another chapter which deals with being weak muscles. Scleroderma, dealing with the skin, and pernicious anemia, which is dealing with vitamin B deficiency, and not being able to produce red blood cells. Okay. So, a normal immune response, we see the invaders come in, and our antibodies come to the rescue. Okay, so in the second, when they get exposed again, we're protected, right? It comes to the rescue, and then now we have these antibodies living through our body. Okay. Now, with the autoimmune disease, somehow or another, one of these T cells or B cells that produce this antibody slip through the cracks. Okay, and guess what? Its variable region, that little white part right here, will bind to either our DNA or RNA or something in our body, and it binds to it. And when it binds, it activates those memory cells, and they become memory cells. And so we're going to keep producing these antibodies, and those antibodies can end up going throughout our whole body and attacking any cells that had that original DNA, RNA, whatever that self-antigen that it originally presented. Major form of treatment would be, immunosuppression. That's about most you can do. So here's a delayed hypersensitivity. Let's see. Here's our picture. So we see the macrophage presents the antigen to the T lymphocyte. Okay, so here's the macrophage chewed up that phagocytosed that antigen. It's going to present it. Now the T lymphocyte is ready to go. It's sensitized. It's mature. It has little spots over here so it can bind to it. Then it goes out and it sees that antigen again, that latex or whatever. And it goes out and it releases its lymphokines. And those lymphokines are going to cause inflammation and cell lysis and tissue destruction. That puretic red inflamed rash. Then last thing we're going to talk about right quick is immunodeficiency, which is almost the same circumstances. People that are immunosuppressed can have some of the same things that go along with immunodeficiency. Okay? And immunodeficiency is where we have a partial or total loss of a few of those immune system components. Okay? And our immune system protects us primarily against infection, and we don't talk about it a lot, but also cancer. Remember those T cells, those cytotoxic T cells, killer T cells? They also, any kind of cancerous cells, they would destroy. Primary deficiencies are basic developmental failure somewhere in the system. Okay, so there's some part of the system, either as it's maturing or after it's mature, that is kind of destroyed. Second, so maybe some kind of cancer produced, they're no longer be able to make those T cells because that cell became cancerous. Then we have secondary or acquired immunodeficiencies. These are caused by specific causes such as infections by HIV, splenectomy, we're removing the spleen, malnutrition, you're not able to make the blood cells, liver disease, immunosuppressant drugs, radiation, chemotherapy. All those are acquired immune deficiencies. Primary deficiencies is some kind of developmental failure. It's probably in your genes. Versus secondary is something that you acquired. Okay. And one of the biggest things we see from immunodeficiencies is going to be the predisposition to opportunistic infections. So we have normal microflora all over our body, inside of our intestines. Okay, they're all over. Everybody has it. Everybody has staph. Okay, but typically it's under control, and it's not the bad kind. It's just Staphylococcus aureus. Normal skin microflora. But people who are immune suppressed end up being in a position where they don't have a very good immune system, right? That's why they're immune suppressed or immunodeficiency. So they end up, that staph can really take off and spread. Or we can see very simple things like a yeast infection take over the lungs or take over our skin, and we can see the all different kinds of skin cancers occur. Okay, because we're no longer killing those precancerous cells. When people who are immune deficient, we usually always try to treat with prophylactic antimicrobial drugs before any kind of procedure. Anything even as simple as teeth cleaning, we always want to treat with prophylactic antimicrobial drugs.